So my goal for this is understanding CKD as global public health problem, to raise awareness about kidney transplantation as an optimal treatment for all kidney failure, and also share the Rwandan kidney transplant program activities and stimulate more discussion. So introduction is this. So the burden of CKD worldwide, we see the CKD definition as many you know, classification and management, and overview of kidney transplantation, immunology and surgery, and also living donor transplantation in Rwanda. So as you know, since 2025, now chronic kidney disease has been recognized as one of the global public health priorities, because it's estimated to touch about more than 850 million, which is 2 times higher than the diabetes population and 20 times higher than the cancer population. And last year, it was estimated to touch about between 5.3 and 10.5 million, which of course were needing some of the renal replacement therapy, either dialysis or kidney transplant. And so, as you know, in low and middle income countries, about 94% of people will not have access to any of the renal replacement therapy due to the heavy financial burden. So among the top 10 leading causes, CKD is among them, and we have about 1.4 million annually attributed to CKD. So 8 golden rules for prevention. So you have to be fit, so physical activities, fluid intake. You have to check your blood sugar and also blood pressure, because those 2 are the main risk factors for kidney disease. No smoking, and also regular over-the-counter, mainly the anti-inflammatory drugs. And also you have to check your kidney function when you have 1 or more than of those risk factors. So hypertension, diabetes, obesity, and also family history of kidney disease. So as you know, this is the kidney classification of CKD. So any abnormalities of the kidney structure or function more than 3 months implicate that you enter in the chronicity. And we use glomerular filtration rate and albuminuria as our independent predictors for mortality risk and CKD population. So the heat map helps to identify CKD patients, but also which are high risk of kidney failure, cardiovascular disease, and also other complications. On the right, this is the different classes that we classify patients using mainly the creatinine and calculating, therefore, GFR. So risk factor associated with the initiation and also progression of chronic kidney disease, as I've said before, so we have hypertension, we have diabetes, we have different cardiovascular disease, we have dyslipidemia, smoking, and on the right we have progression factors. So the age, male are more potent to progress rapidly. The race, black population also due to a poorly controlled blood pressure, poorly controlled also glycemia, proteinuria, and different cardiovascular disease, and smoking, as we said before. So delaying progression. So in the last 30 years, we have been having different drugs, but between 2006 and 2018, we had stuck. We were only having RAS blockade, and in this last 10 years, we have been having different upcoming drugs. So it started with SONAR, which was studying an anti-endothelial A blockade, and also Fidelio, which was studying another endothelial. We had DAPA now. We have also an ongoing on GLP-1, which mainly starting with the diabetic population, but also with extended studies showing also with non-diabetic that it also helps to delay the progression of CKD. So we have hope that in coming years we will have more options, and also we'll be able to mainly focus on prevention to end up in end-stage kidney disease rather than using any of the renal replacement therapy, as they are very burdening either on financial or even on quality of life. So kidney replacement therapy. So we have 3 of them that are well stated with even KidneyGo. So early detection and prevention will never prevent for all patients that we have to end with a kidney failure, even if we put all our efforts. But so some of them will need, of course, renal replacement therapy. So the kidney transplant is one of them. Dialysis is one of them. We have 2 types of dialysis, hemodialysis and peritoneal dialysis. Peritoneal dialysis, currently in Rwanda, we are not having them, but we wish we will introduce it. And also another part, which is comprehensive conservative kidney care that we offer to patients who are not candidates of those 2. So why do we prefer kidney transplant? So there are, if I can say, 5 factors. So life expectancy. If you compare transplant and dialysis, so in 5 years survival, when someone is on dialysis, they have 30 to 45% of survival versus 85 to 90% with kidney transplantation. The quality of life is improved after kidney transplant because patient, I mean, you know, dialysis demand 3 times presence in hospital with 4 hours, and also all the complication with dialysis. And comparing to kidney transplant patient who, yes, take medication, but they can go back to school, they can go back to work, and they contribute to the economy of the country. So treatment burden, as I was saying, it's hemodialysis is very heavy. It doesn't say that transplant is light, but compared to the dialysis, the transplant is still the most preferable one. It has its complication with the infection, malignancy that we will discuss later. The cost consideration also. Dialysis is very cost intensive. Transplant in the first year, yes, it's costly, but when you compare over the years, the transplant is less costly. Environment also, as we were saying, dialysis consumes a lot of water, it consumes a lot of energy, and also we use a lot of single-use plastics, so which generates gas emission. So kidney transplantation, sorry, we'll go all through this rapidly. So usually this is kind of patients, donors, even health workers ask about what happens when you give someone a kidney. So we don't remove native kidneys unless it's needed for some few cases. So the transplant, the graft, is going to be put either on the right or the left iliac fossa. So the artery and the vein will be anastomosis to external iliac, and also the ureter will be anastomosis to the bladder. And they will have a stent in the first few weeks, which will be removed after. So we don't remove the native ones. So every organ donation is a gift to someone who is needed. So kidney transplantation is the best treatment, as we said. It's only one healthy kidney is needed, either for the recipient, even for the donors. Kidney transplantation come from either living or deceased donor. So we are only having a living donor currently in Rwanda, but we hope in the future we will be introducing also the deceased one. So the success for kidney transplantation is about 90 to 95 in the first year, and the graft can last, this study have been done in mainly the developed countries, can last between 15 and 20 years, even more. We have had even more here. So preemptive transplantation is the preferred treatment option. So preemptive means to transplant someone before reaching even dialysis. So they are in end stage, they have signs of kidney failure, but they are not yet on dialysis. So kidney transplantation is the most, the kidney is the most transplanted organ worldwide. So the number of transplants continue to rise as also the CKD patients are rising, and we are challenged by the shortage of donated kidney with a long waiting list for recipient, and as we saw, the survival rate of patient in dialysis is not good. The other challenge is organ trafficking. You have been seeing some documentaries around in the region, and also transplant commercialization and transplant tourism. This is a small history about how the kidney transplantation, so there are some which trials what was done before this first succeeded in 1954, sorry. It was identical twins. That's between 58 and 65, HLA was discovered, and they discovered also antibodies, and they were seeing that those patients who were rejecting were having antibodies. And then they introduced direct cross-match. And between 60 and 70s, we had the first immunosuppressant, azathioprine, which was combined at the time with irradiation and prednisolone. And later we have also introduced T-depleting drugs like ATG. And at the time we had tremendous, at the time it was a tremendous improvement with a 1-year graft survival of 50%. In the 80s, there was discovery of a new molecule, anticalcineurin, which was, the first one was cyclosporine, which is still used now. And at the time, so they introduced the standard tripotherapy, which reduces rejection and mortality. So in the 90s and 20s, they also expanded with advanced immunosuppressive medication, and mainly another anticalcineurin that we use now mainly in the transplant, which is tacrolimus. So what is MHS? So the major histocompatibility complex is a group of genes that's encoded in all nucleated cells with a surface protein. So in human, we call it a human leukocyte antigen. So we have two classes. The first one is, I was saying, present in all nucleated cells and present antigen to CD8 T cells. We have the class 2, which will present on antigen-presenting cells, mainly the T cells with a CD4. So what happened, when you have a foreign body, you have an allorecognition with this immune cell with the ability to recognize that transplant or any other, this is used even in any infection or any other foreign body presented to those cells, and you have recognition of which triggers response against this transplanted kidney. So to have a graft failure, you have to have these trigger signals. So the first one, you have donor antigen. Those we have discussed a major histocompatibility complex, which will be presented with the antigen presenting cells, and this will be engaging with the B7 molecules on that APC and triggers a CD28 of these T cells. The signal 3, because when it doesn't co-stimulate with the signal 3, it can be stopped there. So, but when you have that stimulation, you have a stimulation of EL2, the CD25, which leads to activation of mTOR, and then you have cell proliferation. That's why you have graft injury and graft failure later. So what do we do here currently? What is the process for patients who need kidney transplantation? So we first have our nurse coordinators who educate patients and donors about the advantages, the risk, and then they sign consent. So, and parallel, the patient and the donor are evaluated with a social worker and psychologist, mainly to evaluate the lifestyle, the psychiatric and psychology condition, and also for the donor maybe to confirm the willingness if there is no, if the willing is really genuine, and sometimes if the relationship also is accurate, and evaluate the kidney function. So after they come to medical evaluation, so with a nephrologist, so we have to see in the hall, so the diabetes. Type 1 usually it's preferred to be done concomitantly with the pancreas. We are not doing that here now. We evaluate any infection that can reoccur or actively at the time of evaluation. And also we evaluate vaccination calendars, and we have cancer screening within our guideline and also per age guided, and we assess everything. So cardiac, pneumo, GI, neuro, and also bone and mineral metabolism for the patient. So this is mainly to assess if those two are really fit, because if we don't do it, this compromises also the post-transplant outcome. So after that, we do immunology. So currently, we are not able to do it locally, but we send it outside the country. So what we ask is to perform mainly the HLA, so of all those two, so the patient and the donor, and then we evaluate, we ask also antibodies, and if they have antibodies, they also have to assess if they have what we call donor-specific antibodies, which are the ones that we fear the most. So, and we surgical evaluation also comprise assessment of the vascular anatomy, patency, obesity, because for some obese patients, it can be very tricky to transplant them. And also the need of simultaneous native nephrectomy, as I've said. They assess also by CT or MRI if needed. So after that, so we completed what we call like a medical evaluation if everything is okay. So they have also to do through some legal process, and we have set up with Rwanda National Transplant Committee review, and also before that the RIP. So contraindication, we have some which are absolute, we have some which are relative that we assess patient after, but someone who has an active malignancy cannot be a candidate, but there are some malignancies that they can be treated, and we give them some time for remission and then come back for a reassessment. Severe uncorrected cardiac disease, also this is a relative one, because for some patient can recover and then come back. Unstable psychiatry disorder, and also ongoing and health compromised non-adherent behaviors, mainly for patients who have had transplant and stopped medication, so you have to assess that one. Active infection, HSV is not among them, because now in guidelines can be treated after. We have also obstructive lung disease. We have stroke with also progressive central neurodegeneration. We have, as I was saying, positive T cells when you have donor-specific antibodies. This is also a contraindication. Cirrhosis, because it needs also a liver and kidney transplant concomitantly. So this is the list. I'm not going through in details, but this is the list of disease that we fear to be recurrent after, and the risk is on the risk in percentage is on the right. So the main challenge for us is this, as you may know, this disease mainly touches a young population, and still the burden we have is they usually present to us late, and we don't have the opportunity to do biopsies and diagnose them. But when you have that chance, we have to educate them about the recurrency. So kidney transplant surgery, what happens? So it can be done with an open nephrectomy or a laparoscopic assisted or robotic assisted. So currently we are doing open and laparoscopy on the ground. We have also, we can be preserved in cold storage or machine-driven pulsatile. So for the machine, it's mainly for the deceased donor that have to travel long distance and spend a lot of time out of the body. So what we call cold ischemia, because cold ischemia also is a definitive contributor to delayed graft function. So we have, as I've said, we anastomose the vein to the renal vein to the external iliac and the artery to the external iliac artery, and we have the ureter to the cystostomy. So surgery complications mainly occur in the first months, even the first weeks. So you can have wound infection or wound dehiscence, mainly for those patients who have central obesity, who are diabetic, who have delayed healing, and who have vascular complications like bleeding, renal venous artery, and thrombosis, which is an emergency. We have also some lymphocell, we can have some urine leak in the abdomen, or even urethral obstruction. So immunosuppression. So immunosuppression compromise, so we have an induction therapy. We usually use 2 of them here. So we have a polyclonal lymphocyte, The one we use is a rabbit, anti-thymocyte globulin. We have also monoclonal anti-CD20, which is non-depleting agent. So we use it for those we call low-risk patients. There is another one also on the market, which is an anti-CD52, alemtuzumab. So this is for induction, and we induce also with high dose of steroid concomitantly with one of this induction therapy. So for the maintenance, we have to have 3 sort of immunosuppression. So steroid, with a common side effect being Cushing's syndrome, with some metabolic abnormalities. We have some neuropsychiatric complication, mainly for those old patients. We have anticalcineurin inhibitors, as I said, tacrolimus and cyclosporine. Mainly we use tacrolimus. It has also some side effects with also newly onset of diabetes mellitus. We have also from those ones who have toxicity, they can have tremors, they can have alopecia, they can have gingival hyperplasia. We have also for anti-metabolite. So anti-metabolite, we have mycophenolate mofetil and also azathioprine. The main side effects are hematological and also liver. We have also another one, target rapamycin with the sirolimus and the everolimus, which we don't use usually here. And we have another one, belatacept, which is used mainly for those ones, what we call marginal transplant, old patient with a very cardiovascular risk. The only risk for them is for EBV, is EBV IgG recipient, because it has a high risk of post-transplant lymphoproliferative disease. And also, if you compare with calcineurin, it has more risk of rejection than the calcineurin. So at least a transplant will have a lifelong regimen between 2 to 3. So either tacrolimus with mycophenolate with prednisone plus minus steroid. So complications, in the first month we can have delayed graft function, we can have ATN, we can have hyperacute rejection, we can have, I said, different surgical complication. Between 1 and 6 months, we can have also still have some risk of rejection. We have some opportunistic infection like cytomegalovirus, BK virus. We have PCP. We can have drug toxicity due mainly to anticalcineurin. You have no data, as we said. In the more than 6 months, still you can have recurrent primary disease, those ones I've shown you before. Glomerulonephritis. We have cardiovascular risk is the major cause of risk, even on the long term for transplant patients. And we have also malignancy and metabolic complications. So what do we do in post-transplant? Immediate post-op, we mainly struggling with immunosuppression, fluid and electrolyte management. Also managing hypertension, as you know, with a high dose of steroid, blood pressure tends to go high, hyperglycemia also, anticoagulation. And so we have immunosuppression therapy. So in the first 3 months, they have to be on antibiotic therapy prophylaxis. So for fungal, for PCP, and for hepatitis when it's indicated. So in the long term, so immunosuppression has to be, we have to have a strategy to prevent non-adherence and avoid also severe immunosuppression complication. So you have to assess graft function, treat long-term complication, mainly the cardiovascular and infection, and also do cancer screening regularly. So survival, for the transplant, over 1 year, it's a very good survival rate between 95 to 98, and over the years tends to decrease with a 75 after 10 years. So a kidney allograft, I say, lasts between 15 and 20 years, and the common cause of death is cardiovascular. Transplants may need multiple transplant over the lifetime, may need the pediatrics ones, and the ones have been recorded is 4. Survival rate, depending on also the source of the allograft, because of the age count a lot, and recipient and donor age, comorbidities, condition, and the degree of immunosuppression. This is what I was saying. So donor outcome. Also, this is to also make aware everyone that the donor, living donor is safe, and it's carefully selected donors. We really tend to be very, very strict on donor selection. Perioperative mortality is very low, 0.03%, and most of donors within 3 to 6 weeks, they return to normal activities. A small increase in studies when they were following long-term risk. They have a small increase in end-stage kidney disease, preeclampsia, hypertension, and metabolic disease, mainly as gout. So as well-prepared donors have shown to have a very good quality of life, like similar to the normal population, and have a lower rate of donation-related regrets. This is what I was saying. So this first graph show that they have no more lifespan than the healthy population, and also the incidence of end-stage kidney disease is similar to the normal population. So kidney donation, it's safe. That's the main message. So where are we? Here in Rwanda. So according to the MOH, we have 4 to 25 prevalence of CKD. This is mainly data from hospitals. The age-adjusted death rate for kidney disease is 23.2 for 100,000 population. So first kidney transplant was done here in Rwanda outside in 1999. We had the first campaign in 2013 with 3 patients. And there is a study of one of our colleagues here who looked at a patient who went abroad. We estimated around 120. And we started since March 2023 a new national program with collaboration with the University of Michigan, and now we are fully local. So most of patients that we treat are CBHI patients, more than 90%, because it was allowed to cover those services. We still have some gaps, but the tremendous effort was made. So we have around 217 candidates enrolled on different stages, and currently we have 89 transplanted patients. We have had, unfortunately, 4 deaths and 2 graft loss over the 89. In transplant team, we have a lot. It's not only nephrology. So we have transplant surgeon, we have anesthesia, we have resident, we have nurses, nephropathology, pharmacists, social workers, do almost all tests except the HLA, as I've said. And we have nephropathology lab at King Faisal, which can perform light microscopy and immunofluorescence with the C4D, which is the test we do for immune complex rejection, and we can get results within 40 to 72 hours. So this graph down shows the estimated timeline we do for evaluating one couple. So we estimated between, around 2 months to finish all the things that we have to do. So these are 2 studies. One was done last year when we had only 64 patients and looked at 18 months survival. And it was, for the patient, it was 95.4, and for the graft, it was 94.1. And this, on the right, was that study done with Dr. Theophile, who looked at patient who underwent kidney transplant abroad, and it was published this year. So down here, it was showing over the survival rate over 1 year, 5 years, and 10 years. So it was decreasing 97, 71, and 61 over 10 years. So this is the Declaration of Istanbul. So organs for transplantation should be equitably allocated within countries and jurisdiction to suitable recipient without regard to gender, ethnicity, religion, or social or financial status. So we are acknowledging all these people who have been helping us to do all this wonderful job for the World Kidney Day and also for the kidney transplantation. Thank you.